majority of the topics have been previously covered by my previous speakers, elucidated manner. Now it will be a recap of the session which we have already seen. Next slide. Today we will be discussing regarding a hypothetical case. This case has been given by the Roche guys. Okay, we have got a 70-year-old male gentleman. He lives in the UK. He has a HCV related cirrhosis and had a previous history of atrial fibrillation and hypercholesterol. He was diagnosed in HCC in the year 2010 with a 2 centimeter nodule in segment 4. Next slide. Yeah. In 2010, when he was diagnosed with a HCC, he underwent initially 4 sessions, and the disease was under control for 4 years. In later 2015, he had a left, and he achieved CR after the TACE procedure, and the disease was under control for an year. And in 2016, he had a recurrence, and he further, and the disease was under control for 2 years. And in 2019, he has a diffuse signal abnormality in the segments 2, 4, and 6, which as seen in the figure. At this point of time in 2019, he was having a disease which was not amenable but local therapy, and his AFP levels were high, which is 17,000, which is 1754. Next slide. At this point of time, I just want to take I would like to take the opinion from my panelists. What are the options? What are the therapies we would like to consider in an unresectable HCC patient? And what are the comorbidities you would like to look into before proceeding with the therapy? And what is the fitness assessment you would like to do? First, I would start with Dharmesh sir.
I think the story in this patient dates back to almost 7-8 years ago.
Yes, sir.
And of course, the comorbidities that you mentioned, as also the age, would not come in the way, and we will all go with the performance status of the patient. And atrial fibrillation per se or dyslipidemia is not a contraindication to considering somebody for transplant. Having said that, you haven't mentioned the alpha-fetoprotein at the outset, as also at least the imaging is limited whether there was any vascular invasion or not. So the definitive treatment for HCC this size, as has already been alluded to in the management algorithm talk, would be the transplant if this patient is found worthy of transplant by way of pre-transplant evaluation. So that is what one would do. Having said that, you might also want to argue that resection is equally good. In its initial presentation, this patient had disease which was local only to segment 2. And we do not know what the extent of total hypertension and tests of liver function were, but just atrial fibrillation or dyslipidemia would not come in the way of a curative treatment.
Yeah.
Now, what was done for this patient is...
he was 82, no, sir, years?
70 years, they said.
And now it is 2010, he was 70.
Yeah,
no?
so that's what I'm saying. So 8 years ago, when you did not have all these options available, I would definitely have considered this patient for resection. Then if there was any contraindication to surgery, say by way of fitness or cardiopulmonary status evaluation, then I think whatever the treating doctors did was fairly okay, because you did not have too many options at that time. Small lesions less than 3 centimeters, RFA is perfectly justifiable. Of course, this patient kept getting the repeat RFAs. We don't know exactly why that happened, whether there was recurrence radiologically or whether the tumor markers were going up. So all that information is not available to us. And then when they found that this disease had become more expansive, they subjected to TACE, which is again not odd. So I think they probably did what one would have done those many years ago in a non-resectable non-transplantable patient, except that at times some of us also use adjuvant therapy in the form of TKIs. At that time only probably sorafenib was available. So I think whatever was done in the yesteryears was fairly okay. If this patient was seen now, then obviously the treatment options are far greater. And probably you would start somebody with a disease across two lobes of the liver in a 70-year-old. We would look for an extra hepatic spread. The treatment options, of course, would be in the form of a systemic therapy. Locoregional therapy still cannot be ruled out, but you would need better imaging to say whether a locoregional therapy would be worthwhile in this situation.
Yeah. Points well taken, sir. Thanks for your insights. And any difference of opinion from either Dr. Mithun sir or Anand sir? Or you?
So I agree to what Dr. Dharmesh Kapoor has said. So only thing is that why were there so many recurrences is very surprising. 4 RFA means were they new lesions or the same lesion?
Yeah,
So we don't know about
is
it.
not there, yeah.
Yes. Now, this patient at the time of evaluation by this hypothetical case, at the time of the presentation, at this point of time, patient was he has no esophageal varices, ascites, or encephalopathy with preserved performance status, and he has been started on atezolizumab plus Bev. Is Dr. Bharat around? I don't think
Yes,
so.
I'm here.
Yeah.
In between,
Do you routine do you routinely evaluate for esophageal varices status before you could start him on atezolizumab?
Yes, so Dr. Rajesh, unfortunately, I learned it the hard way. As I said, one of my patient did develop only one patient in last 2 years, but they did develop variceal bleed. So I don't start atezolizumab till esophageal varices are ruled out, or at least bending is done or sclerotherapy is done that it is not going to bleed immediately.
Okay, thank you. And this patient had been started on atezolizumab plus atezolizumab and bevacizumab, and 3 cycles of atezolizumab have been completed. And post which he has fairly tolerated well, except for grade 2 fatigue and myalgias. Next slide. Post 4 cycles, CT and MR showed a partial response, and patient had a clinical subject-wise improvement. Fatigue subsided, and in view of the ongoing partial response, patient continued to have a same regimen. He completed total 9 cycles of 9 months of atezolizumab plus bevacizumab. At this point of time, patient had ongoing new symptoms, and AFP started increasing, and it was a intrahepatic progression. Now I would like to ask Dr. Anand sir, Anand Kulkarni sir, what are the regimen options you would like to consider, or what are the factors that would make you decide once who have progressed on atezolizumab combination?
Most important factor is the patient is on, in Indian settings, we think about performance status and financial status.
True,
Supposing the patient has tolerated the injections well and its performance status is well enough, probably we'll switch over to either tyrosine kinase inhibitors, probably in the form of lenvatinib, which is better option. But it's very difficult for us to convince any patient to receive so long atezolizumab. Bharat, how many cycles you have given in total?
So one patient had 21 cycles, but it is just one out of all of them.
Dharmesh sir, any comments, sir? How many cycles do you routinely give, sir?
You get medicines for free, so it's not a problem. I'm going to create trouble for Roche. I think it all is response dependent, and I think we should choose our patients carefully. We must inform the patients upfront that there are no stopping rules for this treatment unless the patient decompensates or there is objective evidence of tumor progression. It's in my experience, the proof of progression is not very straightforward once you have resorted to IO. It's far more difficult than locoregional therapy. So that is something to bear in mind. We also don't have much information on how to evaluate Lairad's TR for this group of patients. So again, that is a work in progress. So it's very difficult to know conclusively just based on imaging. I shared some images of patients who had received IO, the case that I showed, but we've seen variable responses in different patients. So again, I think there is no final word on how Lyrad's TR works out for patients on immune oncologic agents. Just to say, Dr. Rajesh, you said that this patient was switched to lenvatinib.
Yes.
So is there evidence that lenvatinib should be used as a second line drug?
No, sir.
Yeah, so that's what this case also highlights. We all treat our patients the way we want to treat them.
Yes, because of maybe logistic reasons.
So did you have any biopsy from this patient? No.
No, sir.
Yeah, because I think the only thing that can lead to a switching and non-response like this is if you are having an immunosuppressive state inside the tumor,
Yes,
or
sir.
if the MSI is high. If the MSI is high, then those are the patients who don't respond, and then lenvatinib can suddenly bring down the alpha fetoprotein after even we give etilobev.
Yeah, I do agree.
Beta catenin also, no? Something.
Yeah, beta catenin also, right?
So I think those are the things to be studied at the outset, not at the time when somebody is been on therapy.
Yeah.
If we had this information right at the outset, then probably those who
Beginning.
have Wnt beta catenin pathway mutations, they don't respond too well. And actually those who have got a high tumor mutational burden or who have got a high microsatellite instability, they tend to respond well. But many of the patients with HCC would not fit that bill. So the incidence of a high tumor mutational burden and MSI is very, very low in HCCs.
Yeah, I do agree with your points. Next slide. So clinicians must balance a broad range of factors in order to reach the treatment decision. As previous speakers also rightly said, it should be a MDT approach. Even from the time of diagnosis, it should be an MDT approach, especially when it comes to a HCC setting. It should include oncologist, hepatology, or a gastroenterologist, pathologist, surgeon, and a very good interventional radiologist, especially when the disease is localized. Apart from these, the most important, not only the disease related or treatment related factors, but also patient preference and the age of the patient, and most importantly, socioeconomic factors, because the majority of these immuno-oncology agents are financially more burden to the patient, and comorbidities also should play a major role. And other factors like tumor factors, like whether is there any extra hepatic spread or major vascular invasion is present or not, what would be the tumor size, meaning whether the patient is a high risk or not, how is the Child-Pugh status score. These all factors should be taken into consideration while moving, while not only at the time of selection of the first line agent and also at the time of progression. Next slide. Hypothetically, suppose this patient was treated in this way. Suppose if we have got a few of the conditions, like for example, hypothetical situations wherein which to wanted to know if the patient had prior varices or if the patient had a baseline hypertension. I would like to take the comments on of Dr. Bharat Patodia. Suppose if the patient had a baseline hypertension of grade 3, 160, 140, or had a history of baseline varices. How do you treat these patients, and do you change your management or control the comorbidities and go ahead with the same combination?
Yeah, so blood pressure is something which I will not, change my treatment options for. Blood pressure can be well controlled, or recently our center also had refractory blood pressures to control by renal artery ablation. The blood pressure is not something for which I can change the theory, but change the treatment options. But probably yes, impending varices are there, or coagulopathy is present. Then probably I will not choose etizobabe upfront.
Okay. And considering his baseline previous history, how would you treat the patient if he has progressed on etizobabe?
Yeah. So now that cabazantinib is available as easily available, so as cabazantinib is available now, so probably I will offer cabazantinib than lenvatinib. But yes, I agree with you. Many off-label use in lenvatinib in this setting, even everybody offers it. But yes, it's not.
Why cabozantinib? Why not lenvatinib?
So it is cabozantinib is approved as a second-line treatment option. It's a paucity of data that lenvatinib post IO whether to offer it or not. I'm not saying it is not effective. I'm saying it is not being studied. So just because cabozantinib is
We can
studied.
use, like you rightly said, many patients are being given this treatment.
Yes,
but it's
I
not
agree, sir.
The second line drug.
Next
True,
slide.
sir.
Can we have a next slide? So, how many of the panelists would decide, especially when it comes to selecting a systemic option, like major invasive invasion or extrahepatic spread? Do you think the presence of these factors would help you in determine or reject any of the therapies? We would take opinion one by one. Dr. Damesh, sir.
So I think this is an easy question that you asked. So if somebody has got an extrahepatic spread, then you know that this is a patient for systemic therapy only.
No, sir. My question is, in systemic therapy,
yeah,
would you choose one over the other, one agent over the other, if these factors are present?
Yeah, so again, then if you did have everything available on the table, for example, what was alluded to a little while ago, and at our center we biopsy these lesions and we try to study what the tumor microenvironment looks like. Though biopsy has its own pitfalls and sampling error is one of them, then it can help you decide. However, if you do not have that, then it will all depend on the patient's ability to spend that amount of money. All said and done, TKI is still cost a fraction of what the IO costs. The problem again with TKIs is that at least with lenvatinib, we are all growing in confidence and we've been able to show some objective response rate. But in the sorafenib era, hardly any one of us used to image these patients. So even in the absence of an objective response rate, we were just happy with the quote unquote improved survival, albeit only of 3 months plus. So I think it will all depend on the patient's ability to spend.
Mithun, sir, your takes on the same.
So I will agree to what Dr. Dharmesh Kapoor has said, that if I'm given a choice, money is not a problem. I would definitely go for Etizobev, but explaining to the patient that we might be gaining a 6 months time only, whether we spend this money for that, which lenvatinib would be a more preferable choice if the patient has, it depends on the amount of extrahepatic spread. When you say extrahepatic,
Hello?
Just some lymph nodes around. Yeah, am I audible?
Yes, now audible.
Yeah. So if there are only some, we have to define the level of extrahepatic spread. If it's an extensive spread outside, I would still not prefer to go or waste his money on immuno, would continue with lenvatinib. But yes, if it's some only periportal lymph nodes, and money is not an issue, I would definitely give him immunotherapy with Etizobev.
Okay. Anand, sir, Anand Kulkarni, sir, your take on the same.
This patient will satisfy, I think, BCLCD if he has extrahepatic spread. Portal vein invasion is probably different, and presence of extrahepatic spread would be different. Portal vein invasion we would have for something else, but extrahepatic spread, I would be skeptical in using the Etizobev.
Okay, sir. I just wanted to add one point, because in this Etizobev trial, we do also have 20% of these high-risk patients which are included, because majority of the trials with other agents have excluded the patients of MVI, major vascular invasion or extrahepatic spread. But this is one trial which has upfront included these patients, and almost to a tune of around 20-25%. That is one of the reasons why I just wanted to bring this point on. And
I totally agree that portal vein invasion only per se will not preclude, but presence of extrahepatic spread and extent would probably preclude.
Oh, yeah. Dr. Bharat, your take on this?
Yeah, I'll just add a major vessel involvement. If it is a tumor thrombus, probably it's okay. But if there is a large blunt thrombus also, let's say it is extending up to the right atrium or something, bevacizumab has a possibility of thrombosis also along with the bleeding. So lenvatinib head-to-head bleeding are same, but thrombosis chance are less. So that is my take. If it's a gross blunt thrombosis associated with tumor thrombosis, then probably I will be a bit cautious to offer.
Oh, okay. Yeah. Next slide. When you see this IMBRAVE 150 efficacy for the patients with MVI and EHS, if you see the patients if they are MVI and EHS are not there, that is around 78 patients at the time of analysis, median OS was not reached. And if the patients who had this MVI and EHS also, around 83 patients were analyzed, for these patients, the median PFS is 6.5 months with the overall response rate of 27 and median OS of 13.5 months. Whereas if you see the same thing when these high-risk patients, like wherever this MVI and EHS are positive, the median OS is as low as 6 months with sorafenib alone, and if with the median PFS of 2.8 months. And these are the difficult patients, yet we see the doubling of median OS and median PFS and response rates of around 27%, almost 3 times to that of sorafenib, that is 10 months. This point I just wanted to elucidate. Next slide. The same has been seen that IMBRAVE 150 exploratory efficacy and safety results of HCC patients with a main trunk or a contralateral portal vein invasion (BP4) who has been treated with the combination, that is atezolizumab plus bevacizumab versus a sorafenib in a global phase 3 study, has also had the same results, like median OS 7.6 months versus 5.5 in sorafenib arm 5.5. Whereas if you see the overall survival with atezobev, it is 21.1 month. Next slide. Would you, one question as rightly pointed out by Dharmesh sir, would you switch this patient from the loco-regional therapy to systemic therapy a bit earlier? Because I don't know why was the therapy given in this way, because it's a hypothetical case which was given to me. Patient had received multiple times loco-regional therapy. So I just wanted to know from the hepatologist perspective, so at what point of the time they will call it a day from the loco-regional therapy and they would refer to their medical oncology colleague? Dr. Dharmesh sir.
So I think the era that you're talking about in those days, even though the evidence for use of sorafenib, and that was, mind you, the only agent available 8-9 years ago, as an adjuvant to a loco-regional therapy, even though there was no evidence in published literature to prove the same, was still a very common practice. And I think all of us, including P.N. Rao sir, would have used sorafenib along with the loco-regional therapy. So I don't think this question would really be valid in that era. In the current era, when you've got all modalities available with you, as Dr. Kulkarni already mentioned, that there is something called a non-response to an LRT, and that should be respected. And if you find that somebody is not having the predicted response to LRT, you should switch to a systemic therapy.
Okay. And any difference of opinion or from either Dr. Mithun sir or Anand Kulkarni sir, any points to add?
I think what, hello.
Yes, sir. Please continue.
No, I think what Dharmesh has said is correct. In the previous days when sorafenib we were using it, randomly we are actually we were almost never assessing the patient. Either the patient forgets us or we forget him. Put them on sorafenib and then it goes on, and then repeating the way which we are doing now with the loco-regional therapy and with the experience, has really seen change in our practices. Over.
Sir, your take, Mithun sir and Anand Kulkarni sir. Do you agree with the previous one, or you want any others? Add any new points to the same?
No, because we had no other option at that time. And as far as TACE is concerned, if we are doing repeated sessions of TACE, it would possibly depend on the cumulative dose of doxorubicin that we are using. As far as RFA, I don't think there is a specific number of times at which we can call it a day. It was all a personal choice, I think.
Oh, yeah. Next slide.
You have to consider transplant, sir, at the earliest stages. I don't know why.
Yeah, transplants should have been the first choice anyway. Maybe they didn't have a donor.
So if you see the data from the IMBrave 150, the number of mean applications of the TACE, mean number of applications and median number of applications of TACE, if you see, it's approximately around 2.9 to 2.5, and it could range anywhere from 1 to 11 for these patients of Atezobev arm. Next slide. If you see the baseline demographics of the patients who had a CR with Atezobev, the median age, sex, region, Asian region, rest of the world, ECOG performance status, child book status, irrespective of all these things. And the most important, whether the patient had a EHS and MVI, as we said, these trial had included around 20% of these patients who had a prior EHS and MVI. We do have got best CR rates with Atezobev when compared to sorafenib. Next slide. Next slide. So this has been previously covered. We would, if the patient had a prior varices, we would first send to a gastroenterologist or hepatologist to manage the varices and either medically or surgically or get a banding done. And then we would proceed with this therapy, because we know, even though in the trial the number of events for the grade 3, grade 4 events of varicose bleeding is same, but in general practice, before going ahead with these kind of agents, we would take a clearance from the gastro or hepatic side from the varices point of view. Does it hold good for even epistaxis? Dr. Bharat, your comments on the same.
Yeah, for grade 1 epistaxis, I think I'll just take as incidental event and I'll not change my treatment options.
Yeah, so I do agree with the same. Even the data says grade 1, I think we can go ahead with. But what they said as per the leaflet also is like, if the patient had a prior varicose bleeding, that should be attended, and post which only should be proceeded to the systemic therapy. Next slide. The same has been told here. The guidelines also recommend for the varices in patients with cirrhosis, and screening is mandatory in this protocol. Patient should have at least undergone an EGD within 6 months of prior to the initiation of therapy, and on screening, if they found any varices, that should be treated as per the standard of care. And once the varices are under control, then they should be proceeded to the Atezobev arm. Next slide. So if you see the number of bleeding events that may occur with the systemic therapy, as told by my previous speaker, Bharat, it is relatively same. When you see either it's a lenvatinib or sorafenib, it's approximately a grade 3, grade 4 is 4. And next slide, if you see with the Atezobev and sorafenib arm, it is 6. Next slide. This slide has been already covered. Next slide. Yeah, so this has been already previously said. How would you manage the patient if he had a prior hypertension? Because now that it is not a absolute contraindication or a relative contraindication, but the guidelines you usually say, if the patient had a grade 3 hypertension prior to the onset of therapy, it is better to control the same and then increase, because at a BEV itself also can increase the hypertension. But now this shouldn't be a big problem, because majority of the times, if the patient is found to have a hypertensive, especially grade 3 and above, we would first control the hypertension and next proceed with the treatment. Next slide. Yeah. So fatigue, do we need to change any management? No, I don't think we should change for the fatigue, especially if it is a grade 1 or grade 2. Only symptomatic management would help. Next slide. I'll just try to conclude it in a minute or two, because majority of the points have been already covered. Next slide. This has been already covered, because with Atezobev arm, the quality of life has been preserved and the grade 3, grade 4 events are very less. Next slide.
Dr. Rajesh, if just one comment from my side, the choice of antihypertensive, there is a theoretical discussion over amlodipine being having some concomitant pathway blockage with IO. So probably as my first choice, if not contraindicated, I will offer CCBs as a BP controlling agent. So just a
Even
comment.
that, yeah, even that is one of the things which have been proposed. And one more thing, what they said, but especially if we had both portal hypertension and systemic hypertension, they would have one also, because give beta blockers that would take care of both portal hypertension too, especially if they had a esophageal varices. But if they have got only systemic hypertension, yes, AMLO is a good choice, but there is no strong evidence for the same. It is
Not strong
theoretical.
evidence.
Yeah, yeah. So I would like to end my talk at this by taking the opinion of PN Rao sir. What would be the main thing that would we should educate a patient, especially if the patient we are planning to take them on Atezolizumab, and what are the safety precautions we should explain to them? Your closing comments, sir. Is sir around?
He's connected, but I'm not sure.
Okay, then we can take the closing comments from Dharmesh sir. So what is your opinion? Like what should be our expectations as a treating physician, and how should we counsel a patient? Suppose if we are taking him for a Atezolizumab on treatment. If you see a new patient whom we are starting tomorrow morning clinic, how should we counsel them?
Right. So I think a few points need to be made right at the outset, even though with increasing experience with these agents, it has been suggested that the category of patients with NASH HCCs, they don't respond as well to IO as the other etiologies. But again, the jury is out. So I would, in a patient who merits an IO, etiology would not play a major role for me. The only important thing is, like I said, and at the expense of repeating myself, we must tell the patient the benefit it offers. We know that there is a proportion of patients, and as you see the Kaplan-Meier curves, they have got a very long tail. So the proportion of patients who respond are likely to have very long-term response to this patient, but it is not as if to say that every patient is going to respond. So with the combination therapy, at best you would see a response rate in about 35 to 40% of patients. The only important thing is the finances that are involved with this treatment, as also the fact that it would need repeated imaging, and we don't have stopping rules. So if someone has been on this therapy and the disease is stable disease, or it is showing objective response rate on serial imaging, this patient would need to continue to be on this therapy. And lastly, because we work in a transplant center, one has to be very mindful of the fact that if someone can be taken to the curative arms of the treatment algorithm, then probably this therapy should be avoided, because the experience with the IO and following that up with transplant is anecdotal. Some centers have tried it, but the results can be very difficult to manage in the post-transplant setting, including graft necrosis. So I think those are the points to be borne in mind when we initiate treatment in a given patient who fits the bill perfectly for IO.
Thank you, sir. It's a wonderful insights.
I think it's a good meeting, wonderful meeting. And the main issue is the finances. That is a problem with the patient, as Dharmesh Kapoor has already told. And that's where, whether something can be done for that one. Hello.
So yes. These molecules are going to be patent protected for a fair length of time, sir. So we don't have the opportunity of having generic molecules coming to the fore. So I think these agents are going to, that's what I think. Yeah.
Okay.
So they would be patent protected for a fairly long period of time. Maybe somebody from Roche would be able to throw light on them, unless they are charitable, and if the number of volumes are
that's what I meant. That's what I meant indirectly.
I think they should. There is a good enough reason to loosen the purse string, because the volumes are increasing, the experience is increasing.
That's right.
Our country needs to generate its own data, and these should be these should be the points they should take into consideration. So we are, of course, here not talking of patients being covered under insurance. So patient has to pay from his pocket, and that should be respected.
I'm not sure, sir, if Indian pharmacy develop any of these such molecules, it is going to be any cheaper or not. Probably they will keep the same rates.
Difficult to say. Difficult to say. This Sofosbuvir story tells us something differently. So when Harmony came in the US, the cost was like astronomically high. So I don't think we can just make a sweeping statement like that, because good thing
I'll
about
take my word back.
yeah, the good thing about Indian pharma is that many people will start doing the same thing. So obviously there's a great chance of prices coming down.
Yeah.
Sir, your closing comments, and we'll hand over back to the Rosh, sir.
Yeah. I think it's been a very good meeting, very great meeting. And also we learned a lot, and then the mutual discussion and the case has gone on well. And thank you very much. Over.